So the webinar started. Folks who are in the waiting room should be admitted. I'll give a minute or so for everybody to join, and then I'll go through some housekeeping stuff. Okay. Welcome everyone, and thanks for taking the time to be on our webinar today. I'm going to go through a few housekeeping details, including interpretation, to make sure everybody is all set with their interpretation and language needs, and then we'll get started. So thanks everybody again for attending. Today's Ask the Expert webinar is on sick day management with GSD1b. Just a few details. If you need language interpretation, we have instructions in Spanish, Italian, and Portuguese in the chat. So you want to click on the little globe icon at the bottom of your screen, select the language you need. Again, these are in the chat also. And then I'll introduce myself. So my name is Blair Stone Schneider, and I'm the Executive Director of the Sophie's Hope Foundation, Cure GSD1b. I'm a 1B parent and advocate. Margot Lafreniere, who is the co-founder of Sophie's Hope Foundation, is also on the webinar tonight. So thanks, Margot. And I say tonight, sorry, it's tonight in my time zone. I realize it's probably earlier in the day for most of you. Sophie's Hope Foundation Cure GSD1b started these webinars as a way to provide disease-specific information to the global GSD1b community from experts in the field of GSD. Our first two webinars were on empagliflozin or Jardiance and diet in 1B, and those are available on the Sophie's Hope Foundation YouTube page, where today's webinar will also be placed in a couple of days. So today's format is a 90-minute webinar, and this presentation is based on questions gathered from the 1B community on sick day and illness management. If there's time at the end, it may be possible that we take some questions from the chat box. So if you have questions, please use the chat. If we have time at the end, I'll select a couple of those and we'll try and get some more answered. But without further ado, our experts today are Heather Saavedra, MSRD, LD, and David Rodriguez Buratica, MD, both of University of Texas Health Houston. And Heather and Dr. Rodriguez are a huge part of the care network for the 1B community in the US and worldwide. They're a tremendous resource for 1B. They see a lot of 1B patients in the US, and they're really an invaluable partner to Sophie's Hope and Cure GSD1b. So we're very grateful for all they do, and especially for them taking the time to put together this presentation and be on the webinar. So I will turn it over to Dr. Rodriguez and Heather.
Thank you, Blair, and hello, everybody. And thank you again for this invitation. Thank you for the foundation for the invitation.
Anyway, as Blair said, I'm a dietitian, and today Dr. Rodriguez is going to talk to you guys about the medical management during illness for GSD1b, and I'm going to talk about the nutrition component of that. And these are our disclosures. So today we're going to answer your questions about sick day management. The information that we give you today is primarily from our clinical experience, but some published information will also be listed in the references. And I think a very important part is to know that because every single patient is different, please discuss your specific care with your provider. We're going to give some general information and some information that is specific to our practice, but your care provider might have some different thoughts, and please communicate everything through your provider. And we're going to start off by talking about managing illness at home. There were a lot of questions about that, which you will see next. So there was a long list of questions related to this.
Well, this was the first question in regards to when there is recovery after a GI illness. So the short answer is 1 to 2 weeks for full recovery, maybe sooner than that. Some patients may have a later recovery. Again, it is key during these first 2 weeks after an illness is to follow up on glucose levels more often. If Dexcom CGM is available or any of the CGMs, then it's also important to look at the trends there. And then look at symptoms, frequency of bowel movements, consistency of bowel movements, presence of clumps of cornstarch in the bowel movement that may explain why you're running low. And there may be adjustments, mild adjustments to cornstarch administration and carb intake during these periods that eventually will get better, and then you're gonna go back to normal. Now, regarding these questions is how do we manage blood sugars at home if patients are vomiting or have diarrhea, but blood sugars are stable, or the hospital? So again, we have several tools to address this problem, to address nausea and vomiting. There are many medications. We are listing the medications that are available in the US and that we are available sometimes worldwide. Sofran is the medication that we use in the US to help with nausea and vomiting. The dose depends upon the age, but this is a medication that it has also the ability to have tablets that dissolve in the mouth. So we use Sofran every 8 hours for control of nausea and vomiting. Now, the other medication that I listed there is not available in the US, but is available in some Latin American countries. The main point with this particular medication, the metoclopramide, is that there has to be some sort of medical surveillance. It is usually a medication that is administered, and then you want to make sure that you don't overdose. There may be other medications worldwide that it's important to know what is the set of side effects that may cause, and it's important to know under what circumstances they're prescribed by the physician. Now, once nausea and vomiting is controlled, then you want to make sure there is a continuous administration of glucose and absorption of glucose. So eventually using, Heather is going to talk about it, but using formulas that administer glucose continuously is the way to go. You could still use cornstarch if the nausea is controlled and there is no vomiting. You could still administer cornstarch, but the key point is follow up on the glucose numbers by finger stick or by continuous glucose monitoring. And if diarrhea occurs, the most common scenario for an acute gastroenteritis is that initially there is nausea and vomiting, and then there's progression to diarrhea for a couple of days. So when diarrhea is present, we could still administer cornstarch to control blood sugars, but it is important that we monitor glucose levels because we may need a little bit of higher dose of cornstarch adjustment to counteract the problem with absorption. And if any of these measurements do not work, then the main key point is that to be able to maintain stable blood sugars, then we need dextrose containing IV fluid. So we're talking about going to the hospital for that.
Okay, so the next question is, how can formulas like Fantomol and Tolerex be used at home to manage blood sugar? I have an X over Polycal and Fantomalt because they are just dextrose, powdered dextrose that you can add water to. Yes, those formulas can be used to maintain glucose, but they do not contain electrolytes. That's why whenever our patients are sick, we tend to encourage them to use Tolerex. We can have them take hourly boluses, so hourly feeds of Tolerex, or continuous drip feeds to meet their hourly carbohydrate requirement. Tolerex is good because it contains electrolytes, which are very important when you're sick. Can patients be given an oral dextrose solution at home to manage blood sugar? If so, what and how much? I want to say first that IV dextrose solutions like D5 or D10 can be very dangerous, so we do not recommend that because it can cause changes in blood electrolytes. That's why, again, we recommend formulas like Tolerex, which I showed you on the previous slide. What is recommended for oral intake of fluids during illness for a patient without a feeding tube? So, and what liquid should we consider to give other than water during illness? So if vomiting and diarrhea are not present, any sugar-free liquid is acceptable. But if vomiting and diarrhea are present, electrolytes become more important. So you can try things like G0, Pedialyte with 0 sugar, liquid IV that's sugar-free. So those are just some different examples that are available in the United States. When is the right time to reintroduce food, cornstarch, and formula after an illness? So we ask patients to reintroduce cornstarch, food, or formula once vomiting has subsided. For diarrhea, we will have them continue cornstarch, but they may need a higher dose. We ask people to closely monitor glucose levels and check for the presence of cornstarch in the stool, the white clumps. So for osmotic diarrhea, so very, very watery diarrhea that presents every time someone eats, it's necessary to stop all intake by mouth for 1 to 2 days and receive IV dextrose in the hospital to control glucose levels. So can a patient receiving IV glucose still eat orally if they feel hungry? And should the IV infusion rate be adjusted to accommodate oral intake? If the medical team has deemed that it's safe for the patient to eat, it's fine for them to eat GSD-friendly foods. The IV rate should not be weaned until prescribed cornstarch doses are well tolerated and glucose levels are consistently above 70 milligrams per deciliter. And then we always encourage glucose monitoring closely during these circumstances to make sure everything is well. Then the next question is, what are GSD approved foods that patients can eat while recovering from GI illness? And does it have to be within the usual carbohydrate limits that you would usually follow? So initially, you begin with small amounts of food, like sugar-free popsicle, sugar-free Jello, sugar-free Italian ice, sugar-free ginger ale, things like that. Broths, saltine crackers, plain rice, bread, baked potato without the skin, plain pasta. As appetite improves and we know that the patient's able to tolerate the feedings or the food, then move on to things like chicken soup or pho. After illness, it can take time to eat normally. So encourage small amounts initially and then increase as appetite improves. And then the last question is, how can we encourage eating at home to maintain blood sugars? So cornstarch should be given to maintain blood sugar. Food should be offered that has carbohydrate in it, ideally 1 hour before the scheduled cornstarch dose. And then carbohydrate-free foods can be eaten at any time.
Okay, now we're going to be talking about the questions about neutropenia and illness. These were the questions. So regarding do all fevers require lab tests due to neutropenia, either constant or intermittent? So here I listed what we call the medical definition of fever with neutropenia. So this particular scenario of fever with neutropenia, it's really key to identify it because in any patient that has fever and neutropenia, we need to treat that aggressively and we need to provide broad spectrum antibiotics under those circumstances. Now, the problem is that we don't know if somebody is neutropenic unless we have the result of the neutrophil count. So every time there is a question about the neutrophil levels down, the best way to answer it, if there is a fever on board, is just to have a CBC, have a blood count to count the neutrophils. Now, if the neutrophils are not lower than 500, then the approach could be different. Now, on any patient with a GSD1b, regardless of the neutrophil count, an initial good approach will be to increase the GCSF, the Neupogen, the filgrastim, or the medication that we're using to increase the neutrophil count during illness and until there is recovery. And then have the CBC drawn, and if there is a fever with neutropenia, with severe neutropenia, then receive broad spectrum antibiotics until the cultures are back. At this stage, the patient probably is going to be in the hospital. But the first thing you can do when there is fever is double the dose of GCSF at home, and then eventually you have time to get the CBC and decide based on that. Now, I listed some red flags in our experience, then they hint you that something else is going on, and that is not just a mild illness, but is a severe illness, and probably the neutrophils are down. Is that definitely the patient is not being themselves, even this is key, especially when the fever is being controlled and when the temperature goes down after administering a, ibuprofen or even sometimes acetaminophen to control the fever, but the patient really looks sleepy, is not acting themselves, is just telling you that something else is going on. We're dealing with a probably severe infection that is spreading and is causing major reaction from the body that needs to be addressed with antibiotics. If the temperature range is very, very high persistently, then there's another aspect to take into consideration and will take you sooner to the hospital. If there are frequent hypoglycemias, if we're not able to control the fever with initial medications, or any other symptom that really, really tells you that we're dealing with a severe infection. If we have an area of the skin that is really swelling and painful and the swelling is increasing, if we have a lot of respiratory symptoms, coughing, wheezing, shortness of breath that require additional a treatment to help with breathing, and or any other sign that on your experience you think that the patient with GSD is not acting well and requires immediate attention. Do we need to increase the EMPA or the Neupogen during illness. So the EMPA, no. And the main reason for not increasing the EMPA is that in general, even though we tend to increase EMPA to the um, minimum effective level, there is probably not benefit of increasing the EMPA during the illness. But there are concerns about the side effects of EPA. Again, there may be issues with hypoglycemias if we increase the dose of the EPA, or there may be issues associated with dehydration if we increase the dose of the EPA. So actually, what we have done clinically, and unfortunately we don't have straightforward answers for this particular aspect, is that if we're concerned about dehydration, and a renal involvement during the infection, it is better that to actually discontinue the EMPA until there is full recovery. Anything that increases the risk for dehydration during the illness, any illness with fever or without it, nausea, vomiting, acute gastroenteritis, it is better to discontinue the EMPA during that short period of time until there is full recovery. If there is good surveillance in the hospital and we know the patient is giving the fluids that the patient needs, that the kidneys are working well and there is no problem with increase of the creatinine in the blood work, the patient is urinating well, then I will say that it will be a case-by-case decision, so the physician may decide to continue on the EMPA. But at home, if you don't have any other way to follow up on it, it's not a bad idea to discontinue the EMPA during illness to make sure that there are no problems with the possible dehydration associated with EMPA because you're peeing more fluid. Now, in regards to GCSF, to Neupogen, or filgrastim, and Avastin, to increase the neutrophil count, it is best during any illness, and this could be certainly infectious or any other possible infection, to increase the GCSF to twice to the regular dose until there is a full recovery. Usually is for 1 to 3 days, but you may need to prolong that increase to make sure that you have enough neutrophils and that they're acting well to help fighting the infection. So this a question addressed the concern about discontinuation of EMPA during illness. So again, anything that causes a increased risk of dehydration, then I think we should stop the EMPA during that time and make sure there is good hydration. And I included these particular circumstances. Now, based on the experience that we have with EMPA, and in adults with diabetes, we know there is an increased risk of a severe inguinal or perineal infections with EMPA. We don't completely understand why is that. So I would say that every time there is an infection in that area, also discontinue the EMPA. And then make sure that during the illness, infectious or not, then once you discontinue EMPA, then you want to make sure that there is good hydration through IV or orally, and then there is a good urine output during the illness. That's key while in somebody who's using the EMPA. If the decision is to continue the EMPA during the illness, I think there has to be some degree of surveillance at the hospital or communication with the physician or frequent labs to assess renal function, to assess dehydration, to make sure there is good oral input and there is no dehydration. In patients with severe neutropenia, how much time do we give ourselves to understand if this is a viral illness or a bacterial? I would say that it's difficult to recognize. The initial symptoms or signs of a viral versus a bacterial. And then things get complicated in general for viral infections because sometimes, even though we're dealing with a viral infection, that particular viral infection could actually suppress the production of neutrophils and other white blood cells that help fighting infections. So anytime there is a viral infection, and we know it's a viral infection, eventually the suppression of the white blood cell count, including the neutrophils, may result in an additional superinfection of bacterial origin. So I will say the safest thing to do is that if you doubt about it and you don't know if it's viral or bacterial, the safest way to do is just to consider that this is a bacterial infection that will result into antibiotic treatment. Now, the only way to know that is running blood work, not only the CBC, but also cultures to be able to culture the bacterial that is causing the infection, but also some viral tests could be done eventually. Rapid viral tests could be done eventually to confirm on that, like a flu test, like a coronavirus test, like adenovirus. Those tests could be done in the hospital to try to understand the type of infection. And under those circumstances, then the management will be different. Probably we're going to hold on antibiotic treatment. Granted that there is always the concern that an initial viral infection could eventually develop into a superinfection by a bacterial, and at that time, antibiotics need to be considered. So to answer this question straightforward, I will say it is better just to consider that we're dealing with a bacterial infection, treat it as much as possible, do the workup that needs to be done, do certainly CBC to get an idea of how is the neutrophil count, because if it's neutropenia with fever, we have to treat it in a different way. And then go up on GCSF and then have runs to define if it's bacterial or not. These were additional questions regarding emergency management. So regarding the recommendations in terms of where wearing jewelry, emergency jewelry, to let providers know or anybody know that you do have a GSD1b. The answer is yes, is best. Um, why? Because there is always the concern that on your daily life there is going to be, unfortunately, a random hypoglycemic episode. And then if you're not with somebody who's familiar with GSD, the only source of information for those who are caring for you at that time and they may find you unconscious due to hypoglycemia is this emergency jewelry. That these are the points that we think is key to include in the jewelry: your name, your date of birth, the contraindications, that your diagnosis of the risk of hypoglycemia, and then so they when the EMS comes, they know how to treat you, giving you dextrose. Um, should provide prohibited medications like glucagon, lactate rangers be listed as allergies in medical history? So yes, we do actually do that. They're not technically allergies because there is not a body reaction against the drug, but they cause medical problems if they're administered to somebody with GSD1 or any GSD1b. So you can list them as allergies and then make sure that this serves as a way for not to receive them. And then you can always explain to the care providers the specifics of it, but I think it's best to list them as allergies. What should the emergency protocol letter contain? So this is actually what we share in our letters of emergency for GSD1 patients. So the diagnosis, the risk of severe hypoglycemia with lactic acidosis, that fasting needs to be avoided, the medications that need to be avoided, glucagon and lactate, and there may be other medications on a personal basis, how to treat the hypoglycemias and the rate that depends upon the age of the patient, and instructions on how to wean IV fluids once um, the blood sugars are stable and oral feedings are introduced, instructions on how to monitor glucose and lactates, instructions on how to follow up the risk of severe infections and to run CBCs and adjust the GCSF administration. We'll be happy to share one sample of our emergency letters if you desire. Tips for what to do in the hospital with the hospital staff. Do not follow the emergency protocol. So again, advocate for yourself and for your family member. So again, the emergency letter is usually, we found it to be very informative and very useful most of the time, but eventually you may encounter the situation of the care provider not necessarily being familiar with GSD, and then some internal protocols, but always insist, and offer the option of communication with anybody who is familiar with GSD in your area, um, and just step on your own feet and just be straightforward, and then eventually recommend additional ways to transmit your information. So try to see if the hospital has a sort of a patient advocate service that you can communicate with, so they understand that you're caring for somebody with a condition that it is rare, and that not everybody has a good understanding of how to treat these patients, and then you're provided the information about it, and then you will like the care team to follow those instructions. But always have clear communications, clear expectations from the beginning, even if it's an emergency, and aim for that. So insist on that. What labs are important to monitor during illness? Again, frequent glucose monitoring is key. Lactates is always important. It's always important to remember that if glucose are in good range, then subsequently the lactate is going to recover. It's not going to recover immediately. It's going to take a little while, but because that eventually concerns some providers. But once glucose is in range, then the lactate, and with good hydration, the lactate is going to improve. Again, for 1B patients, it's important to follow up the neutrophil count on the CBC. We also want to make sure that we follow a comprehensive metabolic panel, particularly to understand what is going on with their creatinine. And this is key for patients with EMPA, because what you don't want to see is that the creatinine that indicates the kidney function is going up. You will be concerning if you see a trend of creatinine going up. Uh, um, uh, Creatinine in general for GSD1 patients tends to be run actually low, and that's not concerning. But again, a creatinine that is climbing up in the setting of dehydration is to pay attention. And a urinalysis is important not from the point of view, not only from the point of view of infection, because it serves to prove urinary tract infection, but also gives you a hint of how well the patient is hydrated. So it's sort of additional general labs to begin with, and to get an idea of how to survey um, for GSD1 patients during illness. When to go to the emergency room? These were the questions that we received. What is the fastest and safest way to raise blood sugar at home? Does this change if the patient is unconscious? So certainly yes. So on a conscious patient, we can always use the oral administration of glucose, whereas in an unconscious patient is more difficult. So I'm going to talk about the conscious patient. So we found that the goal with any hypoglycemia, again, as you know, is raise the blood sugar. So at that time, I think we need to use a simple sugars. So we use dextrose solutions. We found that often just 5 to 10 grams of these solutions that to, content of 5 to 10 grams of these solutions should be enough. However, remember, we need to make sure we double check blood sugar, make sure the blood sugar is up, and as many rounds as you need to increase the blood sugar, you, you, you have to do, you have to do it. And then follow by the administration of the simple sugar. Then because there's going to be a spike and eventually not follow up by a drop, then we need to make sure we administer once that the blood sugar is going up, then administer a complex carb with at least 10 grams of carbohydrates, complex carbohydrates, to maintain the blood sugar steady and don't have that subsequent drop on the blood sugar, rapid drop on the blood sugar. When the person is unconscious, again, the first thing you need to do is you need to call, here in the US, 911, call the EMS, and then you can actually, if the patient doesn't have a G-tube, then you can actually rub the gel, the glucose gel, in the mucous membrane, and that will give you some sort of absorption of a glucose. You don't wanna push any liquid through the mouth on somebody who is unconscious, because then it's gonna be, chances are that it's going to be bronchoaspiration. But you can rub the gel in the mouth, and then seek that the blood sugar goes up. If there is a G-tube available, then you can put the gel through the G-tube, you can pull liquid through the G-tube, you can push formula through the G-tube and bring the blood sugar up. You have to be careful with that. You want to make sure the head is elevated so there is no fluid content going from the stomach into the lungs in somebody who's lying flat. But other than that, that's how you can manage when somebody is unconscious. As many rounds of a gel or liquid dextrose that you need to give, you have to give it. You want to make sure the blood sugar goes back up. Once the person is conscious, then you can think about administering a complex carb uh, um, to hold on that spike on blood sugar. But before that, the only way you can manage is rubbing the gel on the mouth or administer something through the G-tube. Again, glucagon is contraindicated under these circumstances compared to other forms of hypoglycemia. Can glucose be absorbed through the skin in emergencies? The answer is no. Oral glucose will be absorbed through the mucosa, but not through the skin. At what point is in sickness should one consider to go into the hospital? Is it based on symptoms alone or blood sugar or symptoms? So severe hypoglycemia, we need to act on it right away. We need to make sure that the glucose goes up and that the conscious level is recovered. After that, the patient may need to go to the hospital if there was a prolonged hypoglycemia, because there may be lactic acidosis that is uncovered, because there may be other reasons that explain the hypoglycemia that need to be evaluated. It is just safer to go to the hospital and be evaluated. Eventually, some patients know how to deal with hypoglycemia, recover well, and they feel well, and they may not decide to go to the hospital for evaluation. That is on a case by case. But always use your common sense under these circumstances. And then if we anticipate, so the hypoglycemia happened, there was a severe hypoglycemia with loss of consciousness and uh, the patient recover. If we anticipate there may be a reason that explains the low blood sugar and that there may be a problem with absorption of glucose, it is best to be in the hospital. There may be an infection that is brewing. There may be a, an allergy that is present, a food allergy. There may be something else to be evaluated. So it's always good to consider to go to the hospital, and then unless you have full recovery and you feel fine, and there was certainly the hypoglycemia because you missed one dose. Are blood sugars in the 60s for a day or two considered safe when deciding to go to the hospital room or stay at home? The problem that I have with this one is that there should be improvement, okay? And there should be a reason for if you were otherwise fine, having beautiful control and blood sugars over 70, and all of the sudden you have glucoses in the 60s, you feel fine. So one thing to remember is that anybody with GSD1 is used to hypoglycemia and may not have symptoms of hypoglycemia, even though the blood sugars are down. But there should be a reason for it, for those low blood sugar levels. And then behind the scenes, the problem is that the blood sugars are in the 60s, but behind the scenes in the blood, chances are that there is lactic acidosis. So the message here is that even though you may not, if you feel otherwise fine, even though you may not necessarily to go to the hospital, you want to find out why you're running low. Is this because you're using cornstarch that is not working? Is because you have an allergy and then there is problems absorbing cornstarch? Is because there is an infection starting and then you have problem with absorption of cornstarch? It is because you increase your EMPA dose and then you are running low. So there has to be a reason for it. So be very attentive. And the best thing to do is just get evaluated and understand what is going on and then go back home. Or you can do probably plan with a physician, sort of an evaluation, be seen to consider what is going on and then go back home safely. But I think the main thing to answer here is I don't like those levels to be run for more than 2 days and not doing anything. What constitutes a medical emergency GSD1b? So we had spoken about it. So severe hypoglycemia, certainly. So less than 70 with inability to take oral glucose, that is severe hypoglycemia, or with an unconscious a level that is due to seizures or just loss of consciousness. Fever and neutropenia, as we saw it, it is a medical emergency. Inability to tolerate any carbohydrates because you cannot drink them or because you cannot absorb them. And any infection that requires IV antibiotics. Those are medical emergencies. What are the signs of lactic acid from illness that we should look for or be concerned about? So there are two levels for this question. So unfortunately, there may be lactic acidosis that is present and we don't have any symptoms. So suggestions that there is lactic acidosis is just frequent hypoglycemias. So basically lactic acidosis could be asymptomatic sometimes. And patients with GSD1b or 1 in general may be used to higher levels of lactic acid and don't have any symptoms because they've been dealing with that throughout life. So their body has adjusted to it. But certainly it's not something that we want to disregard. It's something that we want to address and tackle. So again, if you're concerned about lactic acidosis because you have hypoglycemias, frequent hypoglycemias, the hypoglycemias need to be resolved and subsequently the lactic acid will improve. Other circumstances where you may have lactic acidosis without hypoglycemia basically include dehydration or severe infections, but usually when that occurs, then you're usually in the hospital. And then some symptoms that eventually some patients have referred is that they have abdominal pain, they do have more frequent nausea, and they may have frequent muscle cramps. And those may indicate that your lactic acid is persistently high and it needs to be addressed. So we're switching gears into the hospital management. These were the questions. How should we wean off from D10 and introduce the cornstarch regimen after illness? So the experience that we had is certainly, so the main message here, the discontinuation of IV fluids cannot be sudden like in any other type of patient. The main reason is that patients with GSD are used to continuous administration of glucose, and as a consequence of that, they have higher levels of insulin. So if we stop the source of glucose, then that insulin is going to bring down glucose levels fast. So a good approach will be to do wean over 4 to 6 hours. Um, Once the patient has tolerated food and has tolerated cornstarch, and we had demonstrated that the patient is absorbing food. It is important this because sometimes, especially when there are GI problems, then there is inflammation of the bowels and the absorption of cornstarch is slower and limited. So we want to make sure the patient gets the cornstarch and the blood sugars are normal. They may be running a little bit high because they are on IV fluids and eating and getting cornstarch. But then at that time, we can safely say that it's time to start weaning IV fluids. And an approach that we've done is once the patient has tolerated the dose of cornstarch and not having any nausea or vomiting, we have demonstrated the blood sugars have gone up after administration of the cornstarch, then start weaning over a period of 4 to 6 hours. A good approach is check finger sticks every hour and then wean by 25%. So if a patient is on 100 mLs per hour, then we check 1 hour later, it's over 70, then, and chances are that blood sugar is over 70 because patient is absorbing cornstarch, then we can wean by 25 ml per hour, is 75. Then the next hour we check again, it's over 70, then we wean down to 50 ml per hour, and so you can do slower wins if you're concerned for over a period of 6 hours. You can even go to an 8 hour period, but it's always an important message to share with the physicians that are caring for you, because not everybody is familiar with this circumstance where there is increased insulin that is going to drive a hypoglycemic episode if we shut off IV fluids containing dextrose. If the hospital doesn't have D10 or it will take time to make it, what should we use instead? So I listed an example here. So bottom line, we need to provide the same amount of dextrose that D10 is supposed to be providing. So it is, chances are that they're going to have some sort of D5. So we do need to administer double the rate of what the emergency letter says. So let's say I give an example. If we're given a D10 is listed in the emergency letter and is at a rate of 50 ml per hour, we need to administer D5 because it has less dextrose, but double the the rate. So we ended up administering the same amount of dextrose per hour. And unfortunately, the payoff is that we're going to be giving more fluids. And the goal is that eventually they do prepare D10 and we use a D10 a long term for prolonged infusion time instead of D5, but 1 or 2 hours of D5 at a higher rate is going to be okay. And that will be enough time for them to prepare the appropriate dose of D10. We also want to make sure that we provide some sort of electrolytes in that solution and that electrolytes are followed long term because these long administration of a higher volume of D5 eventually make cause changes on the electrolytes, and those could be supplemented at some point if they're abnormal. If we don't have a D10, but we have D25 and then to raise the blood sugar quickly, D25 is an option. D25 is not a good option to administer to a peripheral vein for a long period of time. It will be good just for an IV push, and that's it. The problem is that D25 may cause some irritation of the vein, so you want to make sure you have two working IVs because you may lose one of the IVs when you push D25. And that's the dose that we use for D25. Can a patient receive IV glucose is still eat orally if they feel hungry? Should the IV infusion rate be adjusted, increase or decrease to accommodate oral intake? So initially, the safest thing to do is the IV is running, the blood glucose is over 70, we start feeding, and the patient is absorbing carbohydrates. It is expected that the glucose is going to be running a little bit higher than usual. But don't worry about it as long as there is a plan to wean the IV fluids at some point. That is going to be the initial issue, but since there are IV fluids running with dextrose, there's not going to be these up and downs that we see typically when we administer just simple glucose on patients with GSD. So there should be a short period of time that the blood glucose is probably higher than 120. That is the time to start weaning IV fluids as long as cornstarch is being tolerated and absorbed. Are there negative effects of long-term to metabolic control or liver function to receiving too much IV glucose, high blood sugars? So the answer is yes, but for a typical admission, you're not on IV fluids for more than 1 or 2 days. So I will say for just short period of time, there is not a problem. But if you are running higher on blood sugar, um, eventually that's something that you want to make sure you control. And why is that? It's because there is increased glycogen accumulation. There is going to be more glucose instability, so there's going to be more production of insulin, and then eventually up and downs on the blood sugar, weight gain, and mild triglyceride elevation, just associated with the extra glucose administration that you're receiving orally or through IV. So um, overall, I wouldn't worry if this is for an admission for another illness, but I will worry more if elevations of blood sugar occur at home during a long period of time. You want to make sure you talk to your team about developing a more carbohydrate-friendly diet that will allow you to have more stable blood sugars between 70 to 110, 120, no more than that, because otherwise there is all the problems that we listed here. If a patient on IV glucose continues to experience vomiting or diarrhea, is adjusting the IV infusion rate the only necessary intervention to maintain stable blood sugar levels? Yes, but ideally the IV rate is, I mean, eventually the doctors have titrated up and down the IV rate, so you have blood sugars between 170 and 110 when you're not taking anything. When you start eating, then the glucose levels are going to go up. But then if they go up, that is the information to tell you that you can safely wean the IV fluids at that time. The main goal with the IV fluids again is avoid hypoglycemia. Eventually, if you have an IV rate where you're present with hyperglycemia, more than 120, 140, then you can slowly wean and always double check the blood sugar. Make sure that after it's been weaned, then the blood sugars remain higher than 70. How can issues of hyperinsulinism be managed for patients who have been on IV dextrose for a long time? Is there a step-by-step approach to winning the avoid big blood sugar fluctuations? So as we discussed, the main issue here is that once cornstarch and food is tolerated, Then there's going to be a short period of time where blood sugar are high, and that is the information that you need to guide the physicians in terms of a plan for winning the IV fluid slowly over a period of 4 to 6 hours, even longer if it's necessary, depending upon the blood sugar checks after starting the wean. How can we ensure that the process of weaning from IV fluids is done safely? Monitoring blood sugars is key. If you have CGM, that's also useful to guide it. And then the communication with the team about a plan of weaning the IV fluids. But checking blood sugar is the main factor. What is the best standard protocol to raising blood sugars in a patient who is unconscious in the hospital? So I had listed this before, but again, defining the patient has a G-tube or not will change your management, because if the patient has a G-tube, you can push liquid with rapid dextrose to the G-tube, making sure you raise the head of the bed, or the gel, or even formula, and double check blood sugars, then administer some cornstarch or some complex carbs. If there is no G-tube, then rubbing the gel, not the liquid, but the gel in the mucus of the mouth may help, and then establish an IV and administer pushes or D10, or as I mentioned, pushes of D25. And these are the dosages of D10 or D25 that this will be happening either by EMS at home or in the hospital, but this is just for your information, the amount of D10 or D25 that needs to be pushed to raise the blood sugar. And then there is a recovery of the consciousness, and then you can treat in a different way, or just followed by continuous administration of D10. Remember, D25 administration, continuous administration, is not a good way to treat hypoglycemia. Should patients be required to have 2 IVs at one time while on IV dextrose? The answer is yes, it's best, especially if there is another procedure plan. You don't always have it. If you have a good IV, always talk to the nurse about it. But the answer is yes. Why? Because there is a good IV to draw blood, and then there is another good IV to administer dextrose-containing fluids. Or if you lose one, then you have another one as a backup. So it's always safer to have 2 IVs. You don't necessarily have to place the 2 IVs at the same time. You can always start one and see how it works. But if you think that, and again, if the team thinks that it's not working well, it's always safer to have a second IV. We found that has been very useful. And I think that ends up the main set of questions. So again, as we discussed, I think we have time for additional questions. Thank you again for the invitation again, and for, yeah.
Oh, sorry, I was on mute. Thank you both again. That's a wealth of information that people can rely on and use as a resource. I do have a couple of questions to start. Again, we will try and take a few questions from the chat. We've got about 30 minutes. So if you have questions, put those in the chat and I'll be looking through those, and hopefully we'll pull up a few. I did have a few questions to start, but also a comment. I wanted to mention this might be particularly helpful for patients outside of the United States. There is an emergency protocol generator that was created by a group of physicians, metabolic physicians in Europe, that might be helpful for some patients. It's at emergencyprotocol.net, and I will put that in the chat also. And what that is a website that will allow you to put in, if you don't have an emergency protocol from your doctor already, and have not discussed it or cannot get one, you can put in patient information, weight, and such, and it will give you a generated emergency protocol. Again, ideally you have one from your doctor. It's already been discussed in advance. If it's not available, this may be a resource that people can use. It was created for that for that use. So, okay, first question. This is in regard to oral rehydration solutions in the event of illness, which both you and Heather covered closer to the beginning. Is there a formula or a recipe for oral rehydration solution that patients can make at home if commercial drinks like sugar-free Pedialyte or Gatorade are not available?
They've gotten away from using recipes to make oral hydration solutions at home just because of the electrolyte imbalances and all of that. So it's best to use a commercially prepared solution.
Okay, and then a follow-up question to that would be, if a sugar-free formula or solution is not available, is it okay? Basically, is it okay to use something that maybe have sugars that we normally wouldn't use if the alternative is dehydration?
I would not use the sugar because you're going to, one, cause blood glucose to spike, followed by a rapid crash. That's one point. But then also, most of these would contain sucrose, which also contains fructose, which is then just automatically stored in the liver. So I would not recommend that.
Okay, thank you. And here's a question revisiting IMPA and GCSF during illness. Could you briefly go over why you recommend stopping IMPA and upping Neupogen?
Yes, so the main thing is that EMPA works. One of the effects of EMPA and the reason why it was used first on diabetes, adult diabetes, is that increases the glucose expelled by the kidney. So we all know that if we are on EMPA and you check your analysis, you're gonna see at some point presence of glucose in the kidney, and that's how it works for as a good coadjuvant for controlling of elevations of glucose. Well, the problem is every time you're expelling glucose in the urine, you're also carrying water with it. And that's why when we take EMPA, we pee more often. So one of the advices every time we prescribe EMPA in general is also increase water intake. So the concern about using EMPA when you're ill, and particularly when it comes to a risk of dehydration, because you're vomiting, you have diarrhea, your oral intake is poor, because you are in a very hot weather, for instance, the concern is that EMPA is going to magnify the dehydration. So the effects of EMPA on the neutrophils are actually long-standing, relatively long-standing. So brief discontinuation of EMPA really is not gonna, the expectation is not really gonna affect a lot of the neutrophil activity, that eventually just going up on the GCSF during that period will help. But my concern is that if you are at the risk of dehydration, and while having EMPA and you're not doing anything about it and you continue on EMPA, then the dehydration may cause more problems than expected. So again, under specific circumstances, you may decide to continue the EMPA while you're in the hospital, when your hydration status is being assessed, while you're getting IV fluids, when your kidney function is being assessed. That's a different story. But for the home management or just regular illness, I think it's safer to stop EMPA during illness and then increase GCSF until you recover and then resume the EMPA. I don't know if that answered the question. I hope this is sort of a key aspect of it.
Great, thank you. Another question that came in is how to get back to management of doses and managing blood sugar after a hospital stay or an illness. For example, for a GI illness or a major infection, do you go back to normal doses? Does your routine change? What do you recommend after an illness?
Yeah, so as we spoke at the beginning, The illness recovery takes a little while, so do not expect that immediately after an illness you're going to be back to normal. So key aspects are glucose monitoring, symptoms. How much symptoms do you have? Do you take your food and your cornstarch? Do you have any pain? Do you immediately have the bowel movement and diarrhea? And then you may need to adjust your cornstarch dose or your carbohydrate intake while you have full recovery. And that's why glucose monitoring is key, because you may need to have a mild increase of your cornstarch just to account for the problem with absorption of carbohydrates that the illness had left. So it takes a little while for that to recover. So you're gonna see by the blood sugar numbers that you're getting better and by your symptoms that you're getting better, and then you can lower back your cornstarch dosages at some point. Eventually, you need to also change the interval. So if you are on 4-hour dose of cornstarch, but you're not lasting enough, so the only way to really know you're not lasting enough is check your blood sugars. If you have CGM, it's useful, but if not, then frequent finger sticks are gonna tell you which way to go. And then you should slowly see that you recover and then go back to normal depending upon symptoms and blood sugars.
Great, thank you. Another question, do you recommend increasing cornstarch doses because of increased metabolic demand due to fever? So we see this question sometimes in the social media groups. People ask, should I increase cornstarch because my child is sick, generally?
Yes, so certainly yes. And the only answer to that, again, the only driver there is going to be frequent blood sugar. So there is fever, you control the fever, but then you're saying that they're not making it to the next cornstarch time, then you can increase the cornstarch and see how it goes, and then recheck again, make sure he lasted until the next scheduled time of cornstarch. Don't do it too much again because you're going to see hyperglycemia and then dropping, certainly. But the key there is going to be frequent blood sugar checks. You can increase by 1 or 2 grams and see how it goes. And if the kid make it to till the next time the cornstarch is administered, then you should be there, but keep monitoring. I will say monitoring is the key.
Okay, here's another one. Is it okay to use Tylenol or acetaminophen during illness, even though it impacts the liver?
Yes, so the best medication, I guess we always advise about it, the best medication to control fevers is usually ibuprofen or other medications on the same class. Um, However, if you don't have an option, you can eventually use acetaminophen for very short periods of time. Same what happened when you have very difficult blood temperatures to control, where you have to do ibuprofen and acetaminophen eventually. For short period of time, there's not going to be major impact of the liver function test. We know that acetaminophen affects the liver, but there has to be very high dosages for that to happen. So I will say go for ibuprofen first, consider acetaminophen for a short period of time, and I don't think there's going to be any major problem if you're in general under good control. If you're under poor control and your liver functions are elevated, then just go for ibuprofen. Some patients have no choice, and because they're allergic to ibuprofen, they do have to use acetaminophen, and allergies to acetaminophen are less common. So if you have to use acetaminophen because you have an allergy to ibuprofen or any similar medication, then acetaminophen is the way to go. Make sure you're using the right dose. So it's always important to use the dose that help to control the fever, because it's not uncommon that we underdose acetaminophen. And again, the problems related with liver and acetaminophen are going to be related to very high dosages. So you want to make sure you stay aware of that. You use the dose that is prescribed for the age of the patient, and make sure the temperature goes down.
Similar question about hospital management. Is there a surgery protocol that is recommended for GSD1b in like the event of an emergency surgery or something like that, or a planned surgery?
Yes. So, for instance, we have a letter for emergencies that we include the key points that we share there: the diagnosis, the risk of hypoglycemia and lactic acidosis, the avoidance of fasting, the avoidance of glucagon and lactate ringer, um, and then the risk of neutropenia and severe infections. Under the circumstance of an emergency surgery, this letter will work. However, we do have a specific letter for planned surgeries because the one aspect that we include in that letter is the risk of prolonged bleeding that we want to make sure the surgeons are aware of and they know how to look for, especially intrasurgically, because you want to make sure they really, really stop bleeding during the surgery and they monitor after surgery for this risk of slow bleeding that eventually may occur. And this is true for 1A or for 1B. So one thing will be to develop a letter that combines both of them, but that's the one aspect that we stress on the surgical letter. There, not only all the aspects of hypoglycemia, frequent infection, but also the information about prolonged bleeding.
Okay, thank you. Another question about EMPA and GCSF and illness. The question is, what is the length of time that EMPA can be held, especially for patients who are no longer on Neupogen? Would you consider asking the hospital to put the patient on Neupogen temporarily during an illness?
Yeah, good point, because we encountered that situation, and I think I had listed on the slides, hopefully it's there, but I didn't talk about it. So we have this new group of patients that have responded very well to EMPA the to the extent that we've been able to completely wean GCSF. So what I advise those patients is always keep the GSF with you. We continue prescribing the GSF and use it double the dose of the previous dose when they're ill. So the advice is that to and this could be something that could be included in the emergency letter, is that this patient used to be treated with GCSF, but under the event of an illness, then even though the patient is in EMPA and you're gonna discontinue briefly during the illness, then cover with GCSF. So this is probably an aspect that we have to do a better job right now under the circumstances and including in the emergency letter. Now, I don't have a straightforward answer in regards to the length of time of discontinuation of EMPA. I will say that once the dehydration risk is over, then you can actually resume EMPA because that's the main reason why we discontinue EMPA during illness, the risk of dehydration. I would say that based on the experience with the adult population, the other reason for which there has to be an extent consideration of stopping EMPA is if there are perineal infections, because EMPA in adults has been associated with severe gangrene, severe perineal infections that you want to stay away of the EMPA until there is recovery of that. So that I will say is the other aspect where you may consider a prolonged discontinuation of EMPA. But if you're in the hospital and a dehydration risk is limited, you're assessing for it, I guess you could consider with your physician resuming the EMPA for other reasons, because you're gonna improve absorption of cornstarch, the GI discomfort is gonna get better. Yep. So it's a case by case decision, and again, there are pros and cons of the decision. Yeah.
Thank you. So a follow-up question on IMPA. This one is in the chat, and I'm going to ask this in light of illness and without illness. The question is, how many liters per day should you drink to stay hydrated while taking IMPA?
Yeah. So in general, that depends upon the age. What you want to see is that if you, a general guide is if you start going more frequent to the restroom, you need to get more water. And it's hard to assess in little children, but if you eventually void a certain volume, then you want to make sure that volume is drunk of water, you know. So what you don't want to see, for instance, is eventually being on EMPA, is that you start going to the restroom and pee less often, because that will tell you that you really, really dehydrated. So it has to be, so that's a general rule. We typically advise between 2 to 3 liters of water a day. We do follow the urine analysis that I mentioned, and we want to make sure the specific gravity in the urine analysis is low, because that is telling you that you're getting enough water. So it depends upon the age, but and it depends upon the response of the patient to EMPA, because some patients are more sensitive and start peeing more often. But as a general rule, if you go more frequent to the restroom to pee, then you need to be drinking after that. And the weather,
Okay.
yes, that's a good point. Weather, if under the humid, very hot weathers, you need to drink more water.
Great, thank you. Another question came in about travel. And do you have any specific recommendations about what to do with an illness while traveling?
Yes, carry your emergency letter. Make sure your emergency letter is translated to a language where just a common hospital, wherever you go, is able to, to understand the letter. Make plans about the travel. So make sure you have a contact person that is familiar with GSD wherever you're going, that could advise you on where to go and who is the right person to reach out in case of an emergency. And then carry your emergency kit, your liquid dextrose, gel dextrose all the time. Make sure it is not expired. And sort of anticipate what are going to be the circumstances in that travel. The weather, you need more water for hydration. Those are the main, I mean, have a plan. I will say have a plan.
Do you recommend patients take an antibiotic with them to use in the event that they were to get sick, or seek out care where they are first?
It's hard to tell because it will depend upon the risk of each individual region and each individual person. So um, again, travel diarrhea is always a concern that sometimes happens. It's hard to recommend a specific antibiotic. Yeah.
Okay. I think that's it. Those are all the questions pertaining to illness. I see a couple here about exercise and glucose. Just a reminder, we have a webinar that we did a few months back with a dietitian, and there is a ton of information in there about exercise and glucose. So I would say go check out the Sophie's Hope Foundation YouTube page. It's webinar 2 with Malaya Mount. You'll get a lot of information there on exercise. So I think that's it. Thank you both. That was an amazing amount of information and incredible to get so many questions answered. I hope that the 1B community knows how lucky we are to have so many resources and so many experts to come on and directly answer questions from patients. It's really invaluable. So thank you both. We're very grateful, and we'll give you back 9 minutes of your time this morning.
Thank you again for the
Thank you.
invitation.
Thanks,
Bye-bye.
everybody.
Bye, everybody.